Hello everyone, welcome to Patho Excellence. In this lymph node cytology video series, we have discussed monotonous small cell pattern in last video. Now, when lymphoid cells are neither small nor large but deceptively uniform, the diagnosis enters the challenging zone of the monotonous intermediate cell pattern, where morphology alone is not enough. So, today we are going to discuss what is the definition and criteria for monotonous intermediate cell pattern, and this is the list of entities in which we can identify intermediate or medium size cell pattern. So, first of all, what is the definition of monotonous intermediate cell pattern? A cytologic pattern characterized by relatively uniform population of intermediate size lymphoid cells. So, small lymphocytes, it is 6 to 12 micrometer, large lymphocytes more than 20 micrometer. So, intermediate cells are in between 12 to 20 micrometer. So, this pattern strongly suggests a lymphoid malignancy once metastasis is excluded. So, cytomorphologically we will judge the size on the Romanovsky stain air smear. So, here this is the small lymphocyte and these are the monotonous population showing size larger than these small lymphocytes, and this is intermediate size pattern. Key features of this pattern shows monotonous population with lack of polymorphism, cells having intermediate size, nuclear features showing irregular or cleaved nuclei, which is a follicular pattern, round to slightly irregular nuclear membrane. Chromatin is moderately coarse to disperse, inconspicuous to prominent nucleoli depending on the subtype of lymphoma. Cytoplasm scan to moderate and background may show lymphoglandular bodies, and in aggressive type like in Burkitt lymphoma there is starry sky appearance. So, if we see differential diagnosis, there are B cell neoplasm, T cell neoplasm and non-lymphoid mimics. B cell neoplasm include follicular lymphoma grade 1. Now, this diffuse follicular cell lymphoma category grade 1, which is now included into follicular lymphoma according to new classification. Mantle cell lymphoma, nodal marginal zone lymphoma, Burkitt lymphoma, precursor B cell lymphoblastic lymphoma. T cell neoplasm include precursor T cell lymphoblastic lymphoma, adult T cell leukemia lymphoma, peripheral T cell lymphoma and Sézary syndrome, and non-lymphoid mimics metastatic small cell malignancies. So, we have to exclude metastatic malignancy first before diagnosing lymphoma of this type of pattern. So, let us see one by one all entities. So, follicular lymphoma grade 1, it is low grade B cell lymphoma and comprising of centrocytes, and by definition if less than 6 centroblasts per high power filled in 10 follicles, then it is defined as a follicular grade 1 lymphoma. And cytologically if we see, it is centrocytic rich and centroblastic poor pattern. Clinically, mostly adults or elderly patients are there, equal gender distribution and rarely less than 20 years in patient. Disease pattern is patient presents with generalized lymphadenopathy, mainly cervical, inguinal, and splenic involvement is common, but extranodal involvement is rare. Its course is indolent but not curable, and there is risk of transformation to DLBCL. So, cytologically, cellular aggregates in the form of nodularity which reflects follicular architecture is present on low power. High power, where cells are mainly centrocytes with scant or absent cytoplasm, cleaved angulated nuclei, nuclear groove may be seen, and clump chromatin with inconspicuous nucleoli. Additionally, bilobe nuclei with deep clefts may be seen, rarely centroblast which having non-cleaved nuclei and slightly more cytoplasm. Few mitosis, Classically, tingible body macrophages are absent, and in background, numerous lymphoglandular bodies and scattered reactive T cells are seen. So, special variant is signet ring variant, where intracytoplasmic immunoglobulin which pushes nucleus to periphery and it mimics adenocarcinoma. And classically, if we perform keratin and mucicarmine, it is negative. So this is a histological section. Here you can see lymph node having effacement by the lymphoma. It is showing non-confluent nodules of different size. So this is lymph node biopsy, and multiple this follicular pattern is seen where varying size of follicles are seen. And in cytological preparation, here we can see this type of nodularity which can be visualized as a cellular aggregates in aspiration smear. Here, monotonous intermediate cell pattern and prominent nuclear irregularity. So you can see nuclear irregularity in most of the cells. These are the small cells, and large population is of this medium size pattern. And here we can see these arrows show larger size. These are the centroblast, and it is having this cleaved nuclei, is having this nuclear dance, and nuclei are not present, and it is centrocytic, while these are the centroblasts. So this is the centrocytic population. Immunophenotypically, surface immunoglobulin is monotypic and bright. CD20, CD10, BCL2 and BCL6 is positive, and CD523 is negative. Cytogenetically, there is gene rearrangement of both light and heavy chain. Hallmark is like T1418 and Q32Q21 along with BCL2 rearrangement, which inhibits apoptosis. And best diagnosis is by FISH, and there is loss of 1Q, 6Q, 10Q and 17Q chromosome arms, and a gain of 1, 6P, 7, 8, 12QX and 18Q or duplication. So here this is the HE section for IHC marker, where CD20 is positive, BCL2 is here positive in the follicles, CD10 is positive and CD3 is negative. So how to differentiate it from reactive hyperplasia? Mostly this is monotonous pattern, where polymorphous pattern in reactive hyperplasia. Tingible body are prominent in reactive hyperplasia, where absent or rare in this category, and mitosis are few. Here in reactive hyperplasia, many mitotic figures are there. And BCL2, classically BCL2 is negative in germinal center. So here you can see this is the section of reactive hyperplasia lymph node, and this is the germinal center which is having negative BCL2, whereas in follicular lymphoma you can see this is the follicle, and these follicles or germinal centers are also positive with the BCL2. So this is the BCL2 classic example of follicular lymphoma. So how will you remember? Centrocytic dominant, cleaved nuclei, absent tingible body macrophage, BCL2 positivity in neoplastic follicles, and there is transformation to DLBCL is common. So this is follicular lymphoma grade 1. Now let's see mantle cell lymphoma. So by definition, it is mature B cell neoplasm, counts for 3 to 10% non-Hodgkin's lymphoma, and derived from mantle zone B cell. Clinically, middle age to elderly patients with male predominance, and generalized lymphadenopathy, hepatosplenomegaly, and bone marrow as well as peripheral blood involvement may be there. And classically, if gastrointestinal tract is involved, there is lymphomatous polyposis. Cytological features, as this is the intermediate size lymphoid cells, resemble centrocytes but not like follicular lymphoma. So there is irregular nuclear contour, slightly indented and cleaved nuclei, dispersed chromatin which is less clumped than follicular lymphoma, and nucleoli are inconspicuous but larger cells may show small distinct nucleoli. Now cytoplasm, moderate in amount, mildly basophilic. Additionally, rarely you can find plasmacytoid lymphocytes. Here no centroblast and immunoblast, and there is scattered epithelioid histiocytes. This is helpful clue. And mitosis variable, which is increase in aggressive tumor. So here you can see this is the mantle cell lymphoma, where cytologically we cannot distinguish it from another category of intermediate cell pattern. So these are the all centrocytic proliferation of monotonous population of intermediate cell pattern. There are variants of mantle cell lymphoma like blastoid, pleomorphic, small cell, and marginal zone like. So blastoid having large cells, high mitosis and aggressive. Pleomorphic, mark ATPI is there, small cell mimic CLL, and marginal zone like having monocytoid appearance. The prognosis is poor, and here you can see these are the cells of mantle cell lymphoma. So immunophenotype is very much necessary to differentiate all the intermediate cell pattern. So here surface immunoglobulin which is strong, gamma, then kappa chain, CD20, CD5 is positive, CD10 and BCL6 negative, BCL2, FMC7 and cyclin D1 which is key marker for this mantle cell lymphoma. So classically when you find CD5 plus B cell lymphoma plus cyclin D1 positivity, consider it MCL. So cytogenetically T1114, Q13 and Q32, cyclin D1 overexpression along with which drives the cell cycle progression to G1 to S phase. So cyclin D1 is the key marker. So here you can see here mantle cell lymphoma, this is the HE section. To remember what are the markers and how will you differentiate all this pattern, I have taken histopathological IHC peak also, because this will be easier for you to remember all the lymphoma. So here you can see this is CD5 positivity, strong cyclin D1 positivity and variable positivity for CD10, negative for CD23 and Ki67 is high. So whenever you have differentiate MCL from follicular lymphoma, you will see CD5 and cyclin D1. So CD5 but CD10 negative, think MCL. Cyclin D1 most important marker. Moderate cytoplasm compared to follicular lymphoma. Sometimes epithelioid histiocytes may be present, and when you see this type of picture, IHC will be or histopathological correlation with immunophenotyping is helpful. So now let's see another category, nodal marginal zone lymphoma, NMZL. So this is primarily nodal mature B cell lymphoma derived from marginal zone B cells. So it is characterized by involvement of lymph nodes without evidence of extranodal or that is MALT or splenic disease at diagnosis. So clinical features, adult or elderly patient, no strong gender predilection and painless lymphadenopathy, often cervical, may be localized or generalized, and primarily nodal disease, so no spleen or extranodal involvement is there, mostly asymptomatic usually, but occasionally will have a B symptoms. Associated condition which is hepatitis C infection. So this is important association. Having indolent behavior, slow progression and long survival is there. It may undergo transformation to DLBCL, which is suggested by rapid node enlargement and increase in large cells, where special variant if pediatric NMZL is seen, mostly having excellent prognosis. So cytologically it is polymorphous, but often intermediate cell predominant pattern may be seen, and cell type is monocytoid B cells with pale gray cytoplasm, central round nucleus, clump chromatin, small nucleoli and centrocyte-like cells, and along with it is having small intermediate lymphocytes. Now mixture varies, whenever it gives it is having mixture, it is give heterogeneous appearance. Additional findings include there is transformed large cells, plasma cells may be prominent, eosinophils may be seen, and background is less clean than follicular lymphoma. So if you see large cells increase in number, suspect transformation to DLBCL. So by morphology you will see all will have a same picture like intermediate cell pattern. Sometimes you may find eosinophils, and this is the nodal marginal zone lymphoma which is confirmed by immunohistochemistry. So here the marker is CD20, BCL2, and negative markers are CD5, 10 and BCL6 and cyclin D1. So CD23 may be positive or negative or may have a weak appearance. So B cell lymphoma negative for CD5, 10 and cyclin D1. It is a NMZL, and this is the diagnosis of exclusion pattern. Cytogenetics may show clonal immunoglobulin gene rearrangement, mutated VH3 and VH4 families, and there is no typical mal translocation, which is important difference. So here this is the histopathological section where you can find, this is how you will see effaced architecture of node, and these are the small cells to intermediate cells with giving BCL2 positivity, BCL6 which is remnant follicle positivity, dendritic network is by CD23, and MNDA having strong positivity, while IRTA1 having strong expression. Here you can see plasma cells, and here in this differentiation you can see this is the Russell body appearance. So what is the relationship with MALT? Maybe it is 1/3 cases may spread to extranodal site and giving a MALT lymphoma, and in pediatric variant in young male same morphology but prognosis is excellent. So how to differentiate it from follicular lymphoma, mantle cell lymphoma? So here follicular lymphoma which is CD10 positive, mantle CD5 positive and cyclin D1 positive. So whenever you find monocytoid B cells triple negative like CD5, 10 and cyclin D1 negative, plasma cell differentiation if seen, and transformation if large cell is increased, so always exclude first mantle cell lymphoma and follicular lymphoma before you stamp it as a NMZL. Now let's see Burkitt lymphoma. It is highly aggressive mature B cell lymphoma characterized by MYC gene translocation and having extremely rapid proliferation. So it is endemic in Africa, where children are affected having jaw involvement, and Epstein-Barr virus is the hallmark. Now sporadic, where it is worldwide. Abdominal ileocecal is commonly involved, and EBV in 30% cases show positivity. HIV related and nodal and bone marrow involvement may be seen in immunodeficiency associated. So extranodal, where jaw and abdomen CNS involvement is possible. Bulky tumor mass, rapid onset and very rapid doubling time. So this is the fastest tumor. High tumor burden, may present as a lymphoma or acute leukemia. And Epstein-Barr virus is the association with this Burkitt lymphoma, and HIV is also associated. Prognosis is very poor because highly aggressive but potentially curable with intensive chemotherapy. Cytologically, tumor cells are medium size, round nuclei, multiple prominent nucleoli, and moderately deeply basophilic cytoplasm. And signature feature is cytoplasmic lipid vacuoles, which is having 1 to 2 micron size. So background shows numerous tingible body macrophages which give starry sky appearance. It is due to high apoptosis. And additionally, you will find numerous mitosis and high cellular turnover. So this is the HE section showing lower magnification, showing sheets of uniform lymphoma cells with interspersed reactive tingible body macrophages, which is giving a starry sky appearance. And cells are showing vacuolization, deeply basophilic cytoplasm, and this is a Burkitt cells. So this is the smear of lymph node imprint, where you will see these are the small lymphocyte along with this the intermediate cell pattern showing vacuolated blastic cells and basophilic cytoplasm. These are the Burkitt lymphoma cells. So CD20, CD10, BCL6 is positive, Ki67, which is increased, and diagnostically when you find CD10, BCL6, BCL2 negative, CD10 positive, BCL6 positive, and BCL2 negative and Ki67 is 100% high, then it is Burkitt's lymphoma. So hallmark, it is cytogenetically MYC translocation, which is 8Q24 and T814 most common. No BCL2 or BCL6 rearrangement is seen. So how we have to differentiate it from follicular lymphoma and mantle cell lymphoma. So it is fastest growing tumor, starry sky appearance, cytoplasmic vacuoles, Ki67 and MYC gene. So now let's see precursor B and T lymphoblastic lymphoma. So B and T cell lymphoma are neoplasm of immature lymphoid cells or lymphoblast, presenting as a mass lesion with minimal or no bone marrow or peripheral blood involvement. If it is involved, then it is termed as acute lymphocytic leukemia or ALL. So LBL means lymphoblastic lymphoma, and ALL having same disease spectrum. Here lymphoblast, if present in only lymph node, it is lymphoma, but bone marrow and peripheral blood is involved, it is called leukemia. Children and adolescents are very commonly affected. If we see the site of LBL, it is skin, soft tissue, bone and lymph node, but mediastinum is uncommon. Whereas in TLBL, mediastinum or thymic mass, patient present with respiratory distress due to compression, and there is lymph node as well as extranodal spread. So general features include lymphadenopathy, hepatosplenomegaly, and in early stage there may be asymptomatic. Cytologically, B and T LBL look similar. So we cannot differentiate B and T on the basis of cell morphology because all the cells are lymphoblast if small cells are there is scant cytoplasm, round nuclei, fine delicate chromatin in inconspicuous nucleoli. But intermediate cells show more anisocytosis, moderate cytoplasm, classically irregular or cleft nuclei, and 2 to 3 nucleoli. Numerous mitosis is seen, which suggests a high proliferation rate. Sometimes you may find cytoplasmic vacuoles and eosinophilic granules. So hallmark is a marker of immaturity of cell, which is TDT positive. So this is the immunophenotype. So here, as all the intermediate cell pattern, the cells are having same appearance, monomorphic population of intermediate cells, size, lymphocytes, and nuclear irregularity, which is showing in the intermediate cell pattern. This is again fine chromatin, and nucleoli are visible in these cells, and this is the high power view where you can find distinct nucleoli. This is the picture of peripheral bone marrow and peripheral blood involvement. So minimal cytoplasm, nucleoli, and fine chromatin. This is a bone marrow smear where T-cell lymphoblastic leukemia shows pleomorphic blast cells, and here you can see elongated or cytoplasmic process. This is called hand mirror conformation. So this is seen in the T-cell acute lymphoblastic leukemia, whereas in B-cell acute lymphoblastic leukemia you will find this type of blastic proliferation, and here you can identify mitotic figure. And sometimes in pediatric B-cell acute lymphoblastic leukemia you can identify this cup-like nuclear morphology. So this is a characteristic cup-like. So here it is hand mirror appearance, here it is a cup-like nuclear morphology. So classical differential is with the help of immunophenotype, which is TDT positive, where in BLBL CD19, 22, CD79 and PAX5 is positive, whereas in TLBL CD7, CD99, CD34 and CD1A is positive. And cytogenetically, BLBL having multiple genetic abnormalities, whereas in TLBL there is TCR gene rearrangement, mainly alpha and delta loci. So differentiating it from Burkitt's with the help of immature blast-like cells, whereas in Burkitt mature B cells, and TDT is the helpful marker. So TDT positive, mediastinal mass, think TLBL, and if it is involving marrow then it is acute lymphoblastic leukemia, and cytologically we cannot distinguish B or T, so we require immunohistochemistry. And BLBL having better in prognosis in children, while TLBL depends on the stage, age and LDH amount. So now let's see adult T-cell leukemia. It is mature peripheral T-cell neoplasm caused by HTLV-1 infection. So it is characterized by leukemic involvement, lymphadenopathy as well as systemic manifestation. So endemic areas are southwestern Japan, Caribbean, Central Africa, and this distribution parallels the HTLV prevalence. So demographically, if we see male predominance is there, and 20 to 80 years age patients are there. Generalized lymphadenopathy, peripheral blood leukemia, and skin involvement, which is most common extranodal site. Key findings are, because skin involvement is most common, skin rash, hypercalcemia and leukocytosis along with the eosinophilia, and there is increased or opportunistic infection by strongyloidosis. So there are variants: acute, which is showing having aggressive nature, hypercalcemia and leukocytosis; lymphomatous, nodes without blood involvement, chronic where mild lymphocytosis and skin lesions are there, and smoldering where skin along with presence of or absence of minimal blood disease. So tumor cells, these are the classic nuclear features which is in the intermediate to large lymphocytes, where you will find highly irregular convoluted nuclei which is called flower cells or clover leaf nuclei. So this is the hallmark of this adult T-cell leukemia: coarse chromatin and prominent nucleoli. So signature feature is flower cells, multilobulated or convoluted nuclei. You may find giant cells with convoluted nuclei and pleomorphism. Immunophenotype, if we see CD2, 3, 5, as this is a T-cell leukemia, T markers are positive. So CD2, 3, 5 positive, 7 may be absent due to loss, CD4 positive, CD30 may or not, ALK negative, CCR4 and FOXP3 positive. So CD4 T cell, CD7 loss and HTLV1 positive, it is this acute adult T cell leukemia. And cytogenetically there is clonal TCR gene rearrangement and HTLV integration is key feature. So here it is having poor prognosis and acute variant having a death within less than 1 year. In this histopatho section, you can see a patient with adult T-cell leukemia where complete architectural effacement without evidence of any follicular structure. And morphologically, these are the clover leaf or irregular nuclear cells. In this section you can identify. CD3 is classically positive, and we have to differentiate it with the PTCL and Caesari, which we are going to discuss in next slides. So HTLV1 viral association, flower cells, hypercalcemia, and CD4 with CD7 loss along with skin, blood and node involvement. So let's see peripheral T-cell lymphoma, PTCL. It is mature T-cell neoplasm. 6% of all non-Hodgkin's lymphomas are of this type. Unknown etiology and typically affect older patients. Generalized lymphadenopathy and frequently extranodal involvement like skin, GI tract, liver, spleen and bone marrow is there, associated with these symptoms along with pruritus, eosinophilia and hemophagocytic syndrome. So leukemia phase is uncommon, so it is helping us to differentiate it from ATLL. Polymorphous pattern and monotonous pattern. These are two patterns. Polymorphous pattern is common, where you find mixture of small, intermediate, large histiocyte, eosinophil plasma cells, so giving heterogeneous background. Less commonly you will find monotonous pattern, which is having single predominant cell population and may mimic other lymphoma. Here the cell size is 12 to 28 micron, clear cytoplasm, which is important clue, irregular nuclei, prominent nucleoli and numerous mitosis. Additionally, sometimes Reed-Sternberg-like cells and clear cells or sarcoid-like granulomas may be seen along with inflammatory cells in background. And if we see immunophenotype, CD2, 3, 5 and CD7 positive, but CD7 may be lost in some. CD43, CD4, CD45 RO is positive, B cell markers are absent. So it is TCR alpha B positive and Ki67 high, where cytogenetically clonal T cell receptor gene rearrangement and there is complex genetic abnormalities common. So here you can find peripheral T cell lymphoma cells showing prominent nuclear irregularity, and here these cells having clear cytoplasm, right? So this is the feature where you can identify peripheral T cell lymphoma pattern. In histological section, this is the cutaneous T-cell lymphoma of small medium pleomorphic, where you can find here these lymphoid cells, malignant lymphoid cells are infiltrating into this is the section from the skin. So overlying epidermis is also infiltrated by this malignant cells. So these are the pleomorphic cells, and some of the cells are large in size in this, and these are classically CD4 positive T cells, and CD8 positive cells are few in number, right? So we have to differentiate it with ATLL, where HTLV1 association is there, and CD7 it is lost here, often present here. So it is the diagnosis of exclusion. We have to first rule out ATLL, Hodgkin's, T-cell rich DLBCL and other T-cell neoplasm, and then we can come to the diagnosis. Generally prognosis is having aggressive nature of this lymphoma is, so prognosis is poor, and small cell variant having relative better prognosis. Now let's see Sézary syndrome. It is aggressive leukemic variant of cutaneous T-cell lymphoma, which is characterized by erythroderma, circulating Sézary cells and lymphadenopathy. Here elderly patient more than 60-year-old and male predominance is there. Classic clinical triad shows erythroderma, where diffuse skin redness is there, generalized lymphadenopathy, and classically circulating Sézary cells in blood. Additionally, there is palmoplantar hyperkeratosis, onychodystrophy, which is showing nail changes, and here this is aggressive disease nature having poor prognosis. Cytologically characteristic cells are Sézary cells, which is characterized by cerebriform nuclei, means brain-like folding. Intermediate size lymphocytes, moderate basophilic cytoplasm. Nucleus is having deep convolution, monocytoid appearance, and 1 to 3 nucleoli as present. Background may show melanin-laden histiocytes due to dermatopathic lymphadenopathy, which we have already discussed in previous small cell pattern lecture also. So here you can find these are the Sézary cells, where these intermediate size cells having nuclei with cerebriform nuclei, and here these are the classic Sézary cells identified in the peripheral blood. So these are the Sézary cells. Immunophenotypically CD2, 3, 5, 4 positive, but ratio is increased because CD8 is negative, and loss of T cell marker like CD7 is sometimes present. Genetically clonal TCR gene rearrangement, and there is complex abnormalities in the form of unbalanced translocation and deletion. So diagnostic criteria A requires clinical as well as lab correlation. So whenever you find Sézary cells in peripheral blood, it must be more than or equal to 1000 per milliliter cube. Along with that, CD4 and CD8 ratio must be greater than 10, and loss of T cell antigen like CD7. So differential diagnosis, we have to differentiate it from ATLL, where you find flower cells. Here it is cerebriform cells. So cerebriform nucleus, leukemic cutaneous T cell lymphoma, erythroderma lymphadenopathy and blood involvement, along with CD4 predominance with high CD4 CD8 ratio, and loss of CD7 is common. Now let's see, other than lymphoma, metastatic small cell malignancy in lymph node which mimic lymphoma, and it will give intermediate, small to intermediate cell pattern. So metastatic small cell malignancy means lymph node involvement is not equal to always lymphoma. So whenever we find this type of cell pattern, we must first exclude metastasis because it mimic lymphoid malignancy. So always correlate with clinical and nodal drainage area. Compare with primary tumor if available, and IHC and flow cytometry is very helpful. So whenever you find absence of lymphoglandular bodies, tight cohesive cluster which is suggestive of epithelial nature, whereas in lymphoma cells are singly scattered, and necrosis and crush artifact is if seen, and cytological atypia not typical of lymphoid cells. These four features if you identify, it is red flags for metastasis. So try to see for primary. Now these are the important metastatic entities include. First is neuroendocrine tumor, which include carcinoid, atypical carcinoid and small cell carcinoma. So neuroendocrine tumor basically having nesting trabecular pattern, uniform cells, fine granular salt and paper chromatin, inconspicuous nucleoli, and IHC profile shows cytokeratin positivity, chromogranin and synaptophysin CD56 positivity. So carcinoid tumor, which is well differentiated NET, having uniform cells and central nuclei, rarely mitosis, and may show carcinoid syndrome. So these are the cellular aggregate with coarse and uniform chromatin, which is characteristic of carcinoid, which is well differentiated neuroendocrine tumor. Now atypical carcinoid, it is less common, but lymph node metastasis are more frequent than the carcinoid tumor, and these cells are having atypical and slightly spindling and having scattered mitosis. So here you can identify this mixture of intermediate cell aggregates, some elongated nuclei, and you cannot identify nucleoli in these cells. So this is atypical carcinoid. Now small cell carcinoma, where these are having size greater than lymphocytes, and mostly it is 2 times lymphocyte size. Nuclear molding which is visible in high power view, crush artifact may be seen, hyperchromatic nuclei with scant cytoplasm, and numerous mitosis with necrosis if present. It is suggestive of small cell carcinoma, and mostly lung origin is common in lymph node metastasis, and which is TTF1 positivity. Now here you can find this type of cellular aggregates, and it is showing cellular molding, coarse chromatin, and nucleoli is absence, which is characteristic of small cell malignancy. So how will you differentiate typical, atypical and small cell carcinoma? Majorly you have to see mitosis, necrosis and pleomorphism. Rare mitosis in typical carcinoid 2 to 10 per 2 mm square, which is in atypical, and very high in small cell carcinoma. And necrosis extensive in small cell carcinoma, focal in atypical carcinoid and absent in typical carcinoid. So pleomorphism, again small cell show marked pleomorphism, moderate in atypical, and pleomorphism minimal in typical carcinoid. So that you can how you can differentiate this all three categories. Now let's see Merkel cell carcinoma, which is showing blue, small blue cells and having prominent cellular dissociation. So whenever you find this type of picture, you may have a picture like lymphoma, but perinuclear dot like cytoplasmic staining, if we identify, it is helping us to rule out Merkel cell carcinoma, and there is no nuclear molding. So if we perform cytokeratin stain, it is giving dot like pattern, and neuroendocrine markers are positive. So here In this smear, some of the cells show perinuclear dot-like cytoplasmic condensation. So here you can find some of the cells show this is the perinuclear dot-like condensation of having aggregates of this chromatin material. And if we perform keratin IHC, then you can identify this dark colored periphery condensation is visible with this IHC marker. So this is the peripheral condensation. So this is the dark staining of keratin stain, immunocytochemical stain. Now basal cell carcinoma, very rare to see in lymph node metastasis, but if it is present, it shows tight clusters and peripheral palisading of nuclei. No molding, clean background, it is suggestive of basal cell carcinoma. Now melanoma, which is a very important mimic because cytologically it is having variable morphology, may mimic lymphoma or plasmacytoma, and malignant pigment if present, we can may diagnose may rule out melanoma if melanin pigment is present. But if it is amelanotic melanoma, it is very difficult. So here in this smear, you can identify these are the plasmacytoid morphology of these cells, which resemble plasmacytoma, but immunochemically it is S100 melan A and HMB45 positive. So here in higher magnification you can identify these are the cells having lymphocyte like cell morphology. It is not diagnosed without help of immunohistochemistry or immunocytochemistry. So here also this is a smear of melanoma where you will find intermediate cell pattern and dispersed cell pattern, and this also having S100 melan and HB45, so it is a metastatic melanoma. Now another category is small round blue cell tumor, which is common in pediatric patient, which include neuroblastoma, Ewing sarcoma, rhabdomyosarcoma. So neuroblastoma, it is characterized by Homer-Wright rosettes, which is commonly seen in histosections but not visible mostly in cytology. So this is how you can identify these are the Homer-Wright rosettes. So rosette like means peripherally having arrangement of nuclei with centrally fibrillar material. So neurofibrillary material, and it will give synaptophysin and chromogranin IHC positivity. If Ewing sarcoma, it will also have a uniform small cell CD99 positive, which is membranous positivity, and there is T11, 22 and EWS-FL1 cytogenetically characteristic. Rhabdomyosarcoma may show spindle or round cell, which is desmin positive, myogenin positive and myo-D1 positive. In all these tumor, primary tumor search is very necessary. Cytologically, if we see neuroblastoma, where you find cellular dissociation with minimal nuclear pleomorphism, and Homer-Wright results are seen, but it is not visible here, and it may be seen in cytology but very difficult to get it. Now Ewing sarcoma, same picture, high cellularity, uniform oval and round nuclei are present. And nasopharyngeal carcinoma, so it is malignant epithelial cell tumor which is showing reactive lymphocytes in background, many stippled nuclei, means without cytoplasm. You will identify large nuclei, but cytoplasm is difficult to appreciate, but IHC is helpful, where in nasopharyngeal carcinoma this neoplastic cells show cytokeratin positivity, EMA, and mostly it is Epstein-Barr associated marker positive. So lymphoma and metastasis, if we want to differentiate, first of all cohesion, lymphoma cells are discohesive, metastatic cells having cohesive clusters. Mostly lymphoglandular bodies are absent in metastasis if whole lymph node is involved by the tumor cells, and mostly lymphoma shows presence of lymphoglandular bodies, but you may find lymphoglandular bodies if partially lymph node is involved. Cytokeratin, if positive, it is suggestive of metastasis. Architectural variability is there, and background is necrotic and having tumor diathesis in lymph node. So this is the immunophenotypic table in which you can identify small and intermediate size cell lymphoma, and you can differentiate it with the help of immunohistochemistry. So what is the diagnostic approach? First of all, you have to confirm whether it is lymphoid origin or not. Lymphoglandular bodies sometimes helps, and exclude metastasis with the help of cytokeratin and synaptophysin chromogranin to rule out carcinoma and neuroendocrine tumor, and flow cytometry to establish clonality, and we have to define whether it is B cell or T cell lineage, and these are the marker list along with the entity of tumor, so that you can easily differentiate with the help of IHC. So whenever you identify this monotonous intermediate cell lesion, cytology raises suspicion, but flow cytometry and IHC confirmation is required, and this will give the truth and guiding us from pattern to precise diagnosis. So this is the master table. Go through this table to remember what is the cytological clues, what are the key markers and genetic and key differentiator in all these monotonous intermediate cell pattern in this lymphoma. So next topic will be the monotonous large cell pattern, and I hope you will now easily differentiate whether this is lymphoma or metastasis, and on the basis of cell morphology, and then you will go for histopathology and IHC correlation. So first thing is to raise suspicion whether it is lymphoma or metastasis or reactive. So if you like this channel, then please like, share and subscribe for more such videos, and thank you for listening. Keep watching. Have a nice day.